Okay, I think we'll get going now. My name is Susan Law. I'm the Knowledge Mobilization Lead for Long COVID Web, and I'm delighted to welcome everyone and wish you Happy New Year and say how delighted we are that we have a guest speaker today who's going to speak to us about long COVID and children. And unfortunately, the second speaker has contacted us this morning and is unable to attend. So this will be a shorter session. We'll be finishing at just after 1:30 today, but we will invite our second speaker back at another time to share her perspectives as well. So we'll just get started with a few introductions to why we're here and have a land acknowledgement. We wish to acknowledge this land on which the long COVID web operates. For thousands of years, it has been the traditional land on the Huron Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Thank you. Just to recap the purpose of why we're here, to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. Secondly, to provide ongoing updates, spotlights on emerging evidence, scientific information about the activities of our national network. And thirdly, to contribute to reducing and managing misinformation about long COVID. We do value highly the engagement around science and its interpretation as well as application. A commitment to reasoned discourse, as stated in our Code of Conduct, comes with the responsibility for all to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we welcome any and all questions and comments in this spirit. And you can see our Code of Conduct via this link, which is also on our website. The cameras and mics are off, but please do post your questions in the chat. We will pause for Q&A after our speaker today, and we will do our best to review and address as many questions as possible. The sessions are recorded, and with permission from the speakers, which we have, they will be posted online following the webinar. And we always welcome your thoughts about how these sessions could be more helpful to you. So please do complete our very short feedback survey, which will be posted towards the end of this seminar. So thank you so much. I'm going to stop sharing here and introduce our guest speaker. We have Dr. Danilo Buonsenso, who is a pediatrician at Gemelli University Hospital in Rome and a member of the research committee of the Global Health Research Institute of the Catholic University of Rome in Italy. He's a PhD in public health and molecular sciences and a postgraduate diploma and master's in pediatric infectious diseases at Oxford University. He's actively involved in several national and international studies and societies in the field of pediatric infectious diseases, specifically in the field of long COVID in children, where he has significantly contributed to advancing current knowledge. So thank you so much for agreeing to come today, Danilo, and I'll turn it over to you for your presentation. Thank you.
Thank you very much for your kind invitation. I'm very happy to be here and having the opportunity to talk about long COVID in children. So I'll try to give a quick overview in these 20 to 25 minutes. And so please, if you have, so the meeting is going to be recorded, but if you have any other questions or doubts who can come into your mind, in the coming days, please feel free to contact me on social media or by email. So I will start by, I received funds to study long COVID, but with really no involvement within any part of my study. So I'm starting with the very first cases I've seen in my practice. And I think these are the very classical long COVID cases that are being described in children and adolescents all over the world. So these were the first 5 children were perfectly healthy children doing their routines, living their lives, going well to school, no previous health, physical or psychological issues before COVID. like many people, they got COVID, usually, as it happens in children, a very mild infection with, upper respiratory tract infections. So the usual mild symptoms described at the beginning of the pandemic, which were happening in several children. But since then, we noticed a cluster of children presenting unusual symptoms for a long time. So the first girl was having persistent anosmia, dysgeusia, tachycardia, and she was unable to do the sport she was doing before. Or these other children complaining extreme fatigue, difficulty concentration, extreme headache, post-exertional malaise, unable to do the sport they were doing before. Or some other children, like this fifth child, having recurrent chest pain. So these children, perfectly healthy, got COVID between 2020 and 2021 and never came back to their routine. And this is how we decided to follow up all our cases in a prospective way since then, because I work as a pediatric infectious diseases. It was already my practice following up children with infections. In my hospital, long COVID was initially described in adults, so we wanted to do the same. And it was already in 2021 when we published the first, probably very unfortunately famous paper on the first evidence of long COVID in children, which it has been actually replicated all over the world by countless studies, even in children. And since then, we are still doing a prospective follow-up, mostly every 3 to 6 months. We are seeing our patients, everyone who got COVID, in order to understand who is recovering, who is developing long COVID, and this is allowing us to have two cohorts of like a control group of children recovered from COVID and children developing long COVID. I think this is an important point on how we define long COVID. So we are seeing children from the catch-up area. We follow up them at 3 months. If they have recovered completely and returned to their previous life, we define them as recovered. If they are presenting persisting symptoms, we still want to exclude other diagnoses because we want to be very specific in the possible diagnosis of long COVID, since long COVID is a clinical diagnosis. If these symptoms, and I think this is a very important point, which is usually missed within papers and even communication, if these symptoms are impairing daily life of children, we eventually make a clinical diagnosis of long COVID. And I think this is a very important point because the impact on daily life and everyday functioning is actually reported in every guideline. So it's not only a child being a bit tired or having sometimes headache or whatever, but those symptoms need to be strong enough to impair everyday functioning. Impairing their everyday functioning in children means not able to go to school anymore, not able to do sport anymore, the usual activities, not willing to do, because these patients struggle to go to school. They want to go, but they struggle because of physical and cognitive malaise. So far we have. I want to focus more on the new things. So in this part, I want to go fast. So we followed about more than 1,500 children. At 3 months, more than 300 of them had the clinical criteria of long COVID. As a comparison, I want to show you everyone in the world has talked a lot about the multisystem inflammatory syndrome, a very serious and devastating disease, but see how much more common is long COVID compared to the multisystem inflammatory syndrome. Luckily, most children self-recover over time, but within this relatively small cohort, we still have children having persisting symptoms at 36 months of follow-up. And you can see that many children, as most children have been infected during the Omicron, have not reached yet the 36 months cutoff. And the most common symptoms are those we know very well from the literature nowadays: extreme fatigue, post-exertional malaise, headache, gastrointestinal symptoms, Actually, very similar clinical presentation as with long COVID, at least in adults. The only difference in my experience is that the GI symptoms are commoner in younger children, but or at least more prevalent and more important in younger children. But this is really it's a cluster of multiple symptoms usually being complained by patients. Although we know that older children, those with allergies, those infected during the initial waves of the pandemic have the higher risk of developing a persistent long COVID. Actually, every child has a theoretical risk of developing long COVID once they get COVID. Of course, adolescents, females, those with allergies have a slightly higher risk, significantly higher risk, but this does not mean that children infected 1 month ago or even younger children may not develop long COVID. The risk is still there. We are still doing, at least less frequently, we are still diagnosing long COVID nowadays in 2025. But I want to focus on newer studies. These data are going to be published next week on pediatric research from the Nature portfolio. And I want to focus on that because today, still 5 years after the beginning of the pandemic, there are still people, including healthcare professionals, unfortunately, questioning if long COVID is a real organic biological disease or it's a lockdown sequela, it's a mental health complication of the pandemic. So we did this study with a very advanced proteomic analysis comparing several cohorts, long COVID, acute COVID, multisystem inflammatory syndrome, and pre-pandemic healthy control. The group was controlled, adjusted by age, and gender. And this is, I think, kind of an impressive results. These data are going to be published next week, but I wanted to share with you. So this is the proteomic principal components analysis, meaning that we can clusterize patients according to a specific proteomic inflammatory profile. We used an inflammatory platform so focused on addressing chronic inflammatory activation in these cohorts. And as you can see, the yellow cohort, it's the children with long COVID. This cohort is perfectly clustered compared to the other cohorts, like the healthy children in green, the COVID children in red, and the MIS-C children in blue. And it's impressive to see how children with long COVID were very well characterized from a clinical perspective, and they had a very similar and overlapping inflammatory profile, really providing a strong suggestion that this disease is overlapping with adult disease as being a real organic inflammatory disease, chronic inflammatory disease. And this analysis was also confirmed when we adjusted the data by time of infection or age of patients. You can see, and actually patients with long COVID even clusterize better than children with multisystem inflammatory syndrome. So it's probably more children have been misdiagnosed with MIS-C rather than those with long COVID. And these patients with long COVID has significant differences in the expression of the same cytokines that have been differently expressed in adults. And these are, I'm not going in details for each of these cytokines, but these are cytokines involved in chronic inflammation, neutrophil activation, and even endothelial inflammation and new vascular genesis. And the most interesting part was that we were able to find a proteomic signature that, at least in this cohort, was very highly accurate in the diagnosis of long COVID, suggesting that a similar test can be really useful, potentially useful if confirmed, of course, on other cohorts for the recognition of long COVID in children and young adults. But we are doing more. Very quickly, we are doing also a microRNA profile in the blood of children. Please don't screenshot these 2 slides because these data are not published yet. As you can see, there are genes that are differently expressed in long COVID and other cohorts. And we found in particular downregulation in some pathways that are implicated in the chronic activation of inflammatory pathways. And in particular, maybe some of you may have heard about a lot of enthusiasm about rapamycin and similar biological agents. And even in our cohorts, there is an abnormal activation exactly of those patients. So suggests somehow reinforcing an important field of research that nowadays researchers, particularly in the United States, are focusing on. So this follow-up allowed us to having also a very good understanding of the clinical presentation. We know that not all patients present in the very same pathway. We can have main clusters of symptoms like the general symptoms, the cardiovascular, the arthromyalgias, the gastrointestinal. And in my feeling is that we are having a growing number of children with a neuropsychiatric cluster of symptoms like brain fog, difficulty concentration, confusion, headaches, and stuff like that. So the point is what to do for these children. Of course, I don't know yet what to do, so I don't have the answer. But not knowing does not mean telling our patients, okay, go home and wait, or go to the psychologist, or go to the psychiatrist. No, meaning that we still have to recognize the disease, because even having a diagnosis can make an initial difference for the families rather than being just dismissed. So this is a very important point. In my opinion, this is probably the most important point, actually. Secondly, once at least research centers recognize the importance of long COVID, it's important to provide implement local guidelines to provide at least support for these patients, because as we will see, some difficulties are possible to be assessed with functional diagnostics, and some symptoms can also be managed with at least with the aim of improving the quality of life of these patients. Local guidelines, I'm not saying we have the proper guidelines, but we have developed a personalized approach, which is based on the most important signs and symptoms complained by patients, like the cardiorespiratory and fatigue being the most common. So I will focus more on them. And what we do, we decided these are dynamic guidances. As long as we are having more and more information about what long COVID is, we will adapt our guidance. So we are having new major discoveries about viral persistence, dysbiosis, autoimmunity, endothelial dysfunction, dysautonomia. So we are focusing on this kind of diagnostics. We can measure posterior orthostatic tachycardia syndrome. We can measure the fatigue. We can measure the brain metabolism abnormalities, at least with the aim of recognizing what is going on in these patients. Of course, it's better to do this within research settings. For example, the cardiopulmonary exercise testing is a routine test so far in our practice. We have documented, but this is already known, that children have several abnormalities compared to healthy controls in cardiopulmonary exercise testing, like inability to finish the test, signs of muscular deconditioning, lung hypertension, or even chronotropic dysfunction, an abnormal chronotropic response to physical efforts. But these tests are also useful to monitor patients over time. This is a child we have treated with some medications, and as you can see, the ability to do the efforts increased, and several abnormal findings improved over time. But we have dysautonomia, the orthostatic intolerance syndrome, and this is easily accessible with a 10 minutes 10 test and a 24 hours electrocardiogram with heart rate variability. This is a child being told, actually the very first child of slide 1, and this girl has been told for like 6 to 9 months that she had a psychological and psychiatric issues. A simple, very simple 24 hours electrocardiogram was able to show us that this child, only waking up in the morning, being in the class, she was living with a heart rate of about 125 beats per minute. And every time she simply stand up, like to go to the toilet, she was, of course, very tired, and her heart rates, just walking a few steps, arrived to more than 180. She was sent to the psychologist, to the psychiatrist. This simple test, for example, allowed us to diagnose inappropriate tachycardia, treat her with ivabradine, for example. And as you can see here, the cutoffs are much lower here. Her heart rate came back to a normal heart rate for a child, like 75, 8 beats per minute, and much less spikes during the day. And we have documented in our publications that the heart rate variability parameters, which are parameters of dysautonomia, are impaired, are abnormal in children with long COVID compared to healthy control. So another thing for recognition. This aspect about the endothelial inflammation is much more about research, but endothelial inflammation is not an hypothesis. This is been documented by countless of studies with the most advanced technologies on the major journals like Cells, Nature, and so on, Science. So it's not an hypothesis. Endothelial and thromboinflammation is actually a thing in long COVID. I'm not saying we have replicated this in children because this was a very small cohort, but platelet hyperactivation was documented in a small cohort in our patients in Rome, and actually was also documented in a small cohort in Lyle Yonker lab in Boston. So again, at least showing us the importance of trying to understand it, studying it more. Considering in the most severe cases, after proper discussion with the families, possible off-label indications, and of course, urging trials. Many children have chronic headaches. This is a mystery to me why patients before COVID, when they had chronic headache, they entered several steps of medications, including gabapentin or others, according to local guidelines. When children had chronic impairing headache since COVID, they were sent to the psychologist. We have simply adapted in our long COVID patients the usual guidelines that every headache society in the world has. So chronic headache, when it's severe and impairing daily life, need to be treated as any other headache. Of course, pacing is important. Guiding patients on how to pace is important. And I'm not going in details, but pacing is nowadays still the most important thing for patients with long COVID. And patients need to be respected and trained. And also family members, school teachers, friends, and doctors need to be trained about the importance of pacing. And of course, mental health support is always important. You know, I'm not saying that the mind and the body are two separated things. Of course, they go together. These children have a disrupted life, and it's obvious that their mental health need to be supported. Of course, we need to collaborate like we are doing today. We are also organizing every 2 months international meetings to share news from the literature or personal experiences, or you are welcome to participate in case you just drop an email here. And I have some other resources, just feel free if you want to access them. I have a blog where I go more in details every Sunday on this topic, and I summarize my journey with long COVID in my book. I did it because we always say patients are neglected because they are not trusted, even in 2025. This happened also to some of the doctors like me, who at the beginning of the pandemic were saying even children can develop long COVID, when most of of the others were only saying that long lockdowns were the cause of long COVID. So this is kind of a hard journey even for us. Doctors trusting long COVID usually struggle to have collaboration with other doctors, and this is a big issue. So all discussed in my journey. So concluding, I can say easily that children are suffering for long COVID for months to years, and children and adults, at least children and young adults, are sharing very similar mechanisms and probably pathways. Some tests are very easy, cheap, cost like few euros, and can at least support diagnosis and monitor and support the management of some conditions. I'm not saying we are treating long COVID, but we can at least improve the control of some symptoms who are impairing daily life. Of course, we need to share each other with parents, and last but not least, as I've said before, several patients actually have myalgic encephalomyelitis, post-COVID myalgic encephalomyelitis. So another neglected disease. Hopefully, understanding long COVID will help understanding myalgic encephalomyelitis. So these are my contacts again, and thank you for being here and for having invited me.
Thank you very much, Dr. Buonsenso. That's just fantastic overview, and the recording will be available for people who would like to review it later. We do have a few questions now. So the first is from Adriana. Do we have data of the risk of reinfections in kids? How the proportion or percent of developing long COVID raises in kids versus adults?
So in adults, there are already studies showing that reinfections can trigger long COVID. In children, we don't have yet formal studies, unless for some surveys from family associations. So we know that this can happen. We don't have numbers yet, but clearly we are diagnosing some children who developed long COVID after the second or third infection, but not after the first one.
Thank you. I think I can hear a radio in the background. If someone has their mic on, they can turn it off, please. The second is, I'd like to just make sure I understand from Carrie. Specific genes have been associated with long COVID. Is this correct? Is it possible to test for these genes and guess if a kiddo will be more likely to get long COVID?
Yes, this is of course potentially feasible. We are not done yet because this will require like thousands, hundreds of thousands of people participating on a similar study. In adults, this has been done, so it seems it's obvious that there is some kind of a predisposition because, of course, a minority of patients who meet COVID eventually develop long COVID because the whole population has met COVID nowadays. So there is obviously a genetic predisposition, in my opinion.
Thank you for that. There's a lovely thank you there from Nandini. And from Candace, for children with chronic tinnitus or tinnitus, post-COVID, are you finding it is improving over time or does it remain static?
5 minutes late. Okay, I'm on the...
So can you repeat, please, this question?
It's a question about ringing in the ears. Different people pronounce it differently. So I'm saying tinnitus post-COVID. Are you finding it is improving over time or does it remain static for children who have this ringing?
Okay, so in general, it improves over time, but not for all. So again, we are not yet able to predict exactly those who will recover over time. When I mention the off-label therapies or need of support for patients, I mean exactly for those patients who are still having severe symptoms after 6, 9, or 12 months. In my experience, those are those with the lowest probability of self-recovery.
Thank you. From Rebecca, in your experience clinically, are there any symptoms of long COVID that you have had better success with for symptom management? Are symptoms
Yes,
better,
usually,
easier to manage?
Yeah, of course, definitely. So usually tachycardia, headache, and pains are, in my opinion, those easiest to easiest, not very easy, but compared to the others, easier to be managed, while neurocognitive symptoms like brain fog and those with severe gastrointestinal dysautonomia, so severe issues with digestion and dysmotility, those are the most difficult.
Thank you. And from Candace, is there a heart rate cutoff for starting ivabradine in POTS?
No, it's not about heart rate cutoff, but it's about how much your heart rate changes during either the 10 minutes 10 test, but I always do both, or even a 24 hours electrocardiogram. So even managing during the day, we usually have patients who are so tired who can just walk around the home, but still they have several peaks of a high heart rate. So it's more a dynamic perspective rather than a single cutoff.
Thank you. I think I know you have to leave in a few minutes, but we have 2 more questions here. From Lynn, I find it jarring that with the knowledge we have now, societies and researchers are not advocating more strongly to prevent more children from getting COVID and possibly developing long COVID. How do we get this message out when public health worldwide seems intent on minimizing COVID's impact on health, both acutely and chronically?
So I think this is entirely true what you said, but I think this is the society has taken their decision. So the society is not adapting non-pharmacological strategies to minimize the risk of infection and therefore the risk of long COVID. So this is, of course, an unfortunate take by the society, by our politicians, but there is, and this is not going to be changed, unfortunately. So I think us as patients, doctors, and whatever, what we can do is fighting, unfortunately, not for prevention, but for treatment, for studies or diagnostic studies, but even more, stop wasting money on epidemiological studies only, but we need a lot of money for pharmacological studies, not only to treat long COVID, but also to treat acute infection, preventing long COVID, particularly in children, because nowadays there are still 0 trials in children with long COVID.
Okay, I'll take one last question. Thank you. From Diana, are there any ongoing pediatric trials that you know of studying efficacy of treating or managing either acute infection phase or long COVID presentation in kids with metformin?
No trials, of course, no trials, unfortunately. And some of us sometimes use them. I also use them. So a trial with acute COVID, I think it's impossible nowadays. This is not going to be done anymore because people think pediatric acute COVID nowadays is not an issue. So unfortunately, I don't expect this is going to be done. And while trials with long COVID, personally, I submitted a short time ago an application for a trial which also includes metformin. But as the society is not informed about the devastating impact of long COVID in children, this also limits somehow, because even healthcare professionals don't know, and the reviewers of grants are healthcare professionals. So this neglecting also limits a lot our chances of winning grants.
Okay. Well, all the best in the work that you do. Thank you so much for your time. It is 6 hours ahead in Italy, and I know you have another something after this. So thank you for sharing some of your time with us. That's fantastic. Thank you everyone for joining us today. There's the short survey in the chat there that you can please respond to so that we can improve our ideas here. And just want to say thank you so much. You've given us some ideas about how we can collaborate with the work that you do too. So thanks so much, and just welcome everyone to join us next time, and take care in this super cold weather we're having here in Canada. Thanks.
Bye-bye.
Bye-bye now.